Hello and welcome everyone to the 21st seminar of the Centre of Research Excellence in Aphasia Recovery and Rehabilitation seminar series. My name is Ciara Shiggins and I'm a postdoctoral research fellow here within the Aphasia CRE and a co-facilitator of this seminar series. La Trobe University acknowledges that this event and our participants are located on the lands of many traditional custodians in Australia. We pay our respect to elders past, present and emerging and extend that respect to First Nations people joining us online today. So today we are joined by Aphasia CRE's own Dr. Caroline Baker, who is based right here at La Trobe University in Melbourne. Today, Caroline is presenting on the management of communication disability in the first 90 days after stroke, a scoping review. We are so excited to have Caroline with us today presenting on this topic. But before we begin, let's cover off some housekeeping. Please be patient with us and the technology today as we have recently switched software platforms to the Zoom webinar package. Our apologies in advance if there are any disruptions to your viewing during this seminar. This seminar is being recorded on Zoom and will be available to access along with past webinar videos via the Aphasia CRE website. Just click on the resources tab, which is at the bottom of the, the seminar tab on the bottom of the resources page. Videos are usually uploaded 2 weeks after each seminar. We also acknowledge that many are facing difficult and uncertain times during COVID-19, particularly our international colleagues. A reminder that the CRE has developed a repository of aphasia-friendly COVID-19 resources, which is also available on the resources tab of the Aphasia CRE website. These resources have been sourced from around the world, and you are welcome to use these in your practice. We have also recently updated these resources to include resources about the COVID-19 vaccine. We have recently switched platforms for facilitating seminar questions. We now use the question and answer function on the Zoom toolbar at the bottom of your screen. Enter your question at any time throughout the presentation, but please keep them brief. You will also be able to see questions asked by other audience members, like or upvote a question to show those of most interest to the group. Dr. Baker will answer as many questions as time will allow at the end of this presentation. Please reserve this Q&A space for questions only and no other comments. And engage with us on social media via our Twitter and Facebook pages. Feel free to tweet along and use the hashtag AphasiaCRE. Finally, if you haven't already done so, please join us as a member of our community of practice. We welcome people with aphasia, family members, healthcare professionals, researchers and organisations to become a member of our aphasia community of practice. Benefits to members include regular newsletter, updates about events and activities, contributions to research, networking opportunities, and many more. The Aphasia CRE is always looking for financial support. If you wish to donate, please see our website for details. And now, I am absolutely delighted to introduce Dr. Caroline Baker, who is a postdoctoral research fellow here at the Aphasia CRE. Caroline's primary research focuses on optimising mental health and well-being for people with aphasia and their family members. Dr. Baker was awarded the Speech Pathology Australia Early Career Researcher Grant in 2019 and the Australian Stroke Foundation Seed Grant in 2021. And in this, she is investigating psychological therapies adapted for people with aphasia. Caroline also works as the research and clinical practice lead for the Speech Pathology Department at Monash Health here in Melbourne. You may also recognise Caroline from previous seminars, as she is also the co-facilitator of this seminar series. But today, I'm delighted that she's here to deliver her own seminar on the topic of the management of communication disability in the first 90 days after stroke, a scoping review. I am so delighted to be able to introduce Caroline here today and to be able to pass over to you now. Thank you, Caroline.
Thank you, Kira. It's lovely to be here with you and to be on the other side of presenting a seminar today for everyone. I warmly welcome everyone along to this seminar. Okay. Thank you, Kira, for the lovely introduction and also for the invitation to present our recent study into the management of communication disability in the first 90 days after stroke, a scoping review. And as I begin, I want to acknowledge my co-investigators, Abby Foster, Sarah D'Souza, Erin Gadecki, Kira Shiggins, Edwina Lambourne, Lucette Lanyon, Ian Kneebone and Miranda Rose. This study was a truly collaborative effort and I'm really proud to present this work on behalf of the whole team. The manuscript for this work has been submitted for publication and it's under peer review at the moment. So hopefully we'll have a publication for you all to enjoy soon. So before we begin, I'd like to take some time at the beginning here to reflect on communication disability after stroke. For the clinicians in the audience today, how do you identify that a person after stroke has a communication disability? How have you and colleagues supported the person? Are they enabled to communicate their healthcare needs? And how have you and colleagues supported the person with communication disability and family members to communicate in the activities of value to them? So I hope today this seminar will allow you to reflect a little bit on your own practice and to also take away some points from the seminar today. There are a number of associated factors that need to be considered when managing communication disability after stroke. I'd like you to have a little think, what are these factors? And I think in current times where we're facing COVID-19 and having to wear personal protective equipment in our clinical practice, this is something that has certainly impacted on our healthcare communication with people with communication disability. So around the world, we are facing that reality, but we also need to consider the person's language and cultural background. We need to also consider the communication activities that are of value to them and the level of literacy that each person has. And if we think about the first 90 days of recovery and rehabilitation post-stroke, we know that the person will transition through various stages of care. For example, between the care of different health professionals on the unit in the hospitals. They'll transfer between hospital units as well. And the person with communication disability will transfer from hospital to the community. So with that in mind, I'm going to share with you a checklist today just to keep us on track with what we'll cover. And I'm really looking forward to sharing with you some of the terminology that's relevant to our study around communication disability after stroke. I'll also share with you the International Classification of Functioning Disability and Health Framework. And we'll talk a little bit about how we can provide assessment and intervention within this framework. And that's been quite a key framework to this study. We'll also cover some prevalence rates of acquired neurogenic impairments after stroke. And we've we've sort of covered a little bit about the importance of managing communication disability, particularly in the first 90 days when people are transitioning through our healthcare systems. But there are some other important reasons that we need to manage communication disability in the first 90 days. So we'll talk about that as well. So for the purpose of our study, communication disability is defined as the impairments, activity limitations, and participation restrictions that affect an individual's ability to interact and engage with the world in ways that are meaningful to them and those they communicate with. And many of you will recognise that this definition is defined by the framework of the ICF. So let's have a little look back at the schematic diagram of the ICF framework. And let's take a little look at the domains in a little bit more detail. So the body functions and structures refer to the actual anatomy, physiology, and psychology of the body. And at this level, we describe the communication impairment of speech, language, and communication. So for example, language-based problems associated with aphasia, speech-based problems associated with apraxia of speech and dysarthria. And activity and participation refer to the person's ability to interact, engage, and participate in everyday communication, valued activities, and healthcare. We also need to consider the contextual factors of stroke and communication disability. So environmental factors may be influenced by access to a communication device in hospital, or it may be influenced by the skills of communication partners and the attitudes of health professionals and others to communication support and disability. And if we think about personal factors, these refer to the survivor of stroke's confidence, their autonomy, quality of life, psychological wellbeing, and mental health. And the framework certainly helps to guide assessments and interventions within these domains for the common and often co-occurring communication disabilities after stroke. So looking here at the prevalence rates after stroke for communication disabilities, they're high. So the high prevalence rates for aphasia up to 36%, dysarthria up to 70%, and cognitive communication disability at 78% demonstrate the widespread problems of communication impairment after stroke. Apraxia of speech also commonly occurs with aphasia and dysarthria. Prevalence data for apraxia of speech is limited due to challenges in assessment and differential diagnosis. In addition to these acquired communication impairments, survivors of stroke may have pre-existing communication problems due to age-related changes or other health conditions such as hearing and vision impairments. And in stroke care units, the prevalence rates for one or more communication-related impairments may be as high as 88% when pre-existing and newly acquired impairments are considered. So effective communication is really vital in our hospitals and community settings, and it needs to be a top priority for survivors of stroke, family members, and health professionals. It is the essential ingredient of clinical care to optimise healthcare access, communication inclusion, and the person's safety. Effective communication is the key to improving stroke rehabilitation outcomes through engagement and participation in therapy, and enhancing the person's wellbeing and quality of life. Without effective communication, there are risks of harmful but preventable adverse events, such as falls, medication errors, dysphagia management errors, And for the person with communication disability, they can begin to disengage and withdraw from therapy and seeking help, support or services in their rehabilitation recovery. So the personal costs and the economic costs of ineffective healthcare communication are really quite high for all stakeholders. But in healthcare, we have the opportunity to manage aspects of communication across the domains of the ICF. And here's another schematic diagram for you. The first domain is represented through the communication-related impairment, such as language and speech-based problems, cognitive communication problems. The second ICF domain is about participation in communication and healthcare. And then we have communication and environmental factors and communication and personal factors. A range of assessments and interventions to target person-centred goals are needed within this framework. And these domains are related, as you can see with the overlapping diagram circles there. And it really is part of interdisciplinary collaboration to manage communication disability after stroke. So let's move on to talk about the first 90 days after stroke. A paper by Bernhardt and colleagues aims to describe the framework that encapsulates definitions of critical time points post-stroke that link to current evidence of the biology of recovery. As shown on this figure, the first 90 days includes the hyperacute phase, acute, and early subacute phases. And management of communication disability in this time period is critical due to the potential for brain repair and neuroplasticity and recovery. So if we also think about the first 90 days, it's also the main period for access to and provision of goal-directed rehabilitation services. The person with communication disability can be living with negative impacts of communication, cognitive, sensory, psychological, and or physical changes in functioning. Family members during this time can take on new caring roles and can experience third-party disability. And there are also questions and discussions about the person's prognosis and their capacity for decision-making after stroke. And efforts to return to activities are occurring during this phase, but we know that there can be low rates of return to work in the medium and longer term. The person with a communication disability can also experience loss of relationships, changes to their identity during this period, and changes in the level of their independence and autonomy. So even with all these challenges, clinicians and researchers are working hard towards trying to understand what can help during this period of recovery. So many of you will be familiar with the VERSE trial, which recently was completed. And this current evidence suggests that there is potential for improved language and communication outcomes after stroke, following treatment in the acute and subacute phases. So the recent randomised controlled trial of an early aphasia treatment called VERSE, Very Early Rehabilitation for Speech, showed significant clinically meaningful gains for participants across all the treatment groups, 12 weeks post-treatment. So this is really promising, and we need lots more research in this area, particularly with larger trials such as VERSE. So we know also during this phase that there are barriers to communication. Health professionals often report reduced skills and confidence in communication support, and we know there are clinical practice related pressures such as time and caseload complexity. And there are values and attitudes of various stakeholders that don't always align with the principles of communication support and therapy. To date, there has been inadequate analysis and synthesis of evidence to underpin the decisions regarding the management of communication disability in the first 90 days. So we aimed to address this through the scoping review study, and our aim was to explore the scope of literature for the management of communication disability in the first 90 days. If we just go back to our checklist, we've covered off quite a bit of ground with background information and the aim of our study. Now I'm going to talk a little bit to you about the scoping review methodology that we used. So a scoping review was chosen as it aims to describe the scope of research literature in an area. It aims to identify gaps for further research and summarise rehabilitation implications. And the study was conducted using the Joanna Briggs Institute Manual for Evidence Synthesis, and it adhered to preferred reporting items for systematic review and meta-analysis extension for scoping reviews, the PRISMA extension for scoping reviews. And up until October 2020, mid-October 2020, we searched 6 databases and we used 22 search terms, which included all types of communication disability post-stroke across hospital and community settings. We had a set of eligibility criteria for studies to be included in the scoping review. So to be eligible, studies needed to investigate acute, subacute or rehabilitation interventions for adults aged 18 years or over with acquired communication disability caused by stroke in the first 90 days post-stroke onset. The primary aim of the study needed to address communication disability post-stroke in at least one of the ICF domains. And here's a little reminder of what those domains were. So the studies really needed to address one of these areas. We wanted to find a cross-section of studies across all domains of the ICF framework. So there were no limitations regarding the type of study design, and we wanted to include quantitative and or qualitative findings. We wanted to include all key stakeholders in the management of communication disability. So we were inclusive of participants with communication disability after stroke. We were inclusive of carers of those people and the health professionals that help to manage communication disability. Studies needed to have original data and they needed to be written in English and published in a peer-reviewed journal. Exclusion criteria were also applied, and these included studies that investigated the onset of stroke beyond 90 days or investigative medical or pharmaceutical treatments. So what did we find? We found almost 6,000 records identified when we searched those 6 databases, and over 4,550 titles and abstracts were screened, and just over 700 potentially relevant full text articles were evaluated. We excluded 583 of the 711 articles, and the most common reason for exclusion was no or ineligible or unclear detail about the time of post-stroke onset. And in the end, we had 128 eligible full text articles included for synthesis. And we extracted the data from all these studies and we summarised the findings using the ICF domains as a framework for our study. So moving along, we've covered off the methodology just briefly, And now I'd like to share with you the results. So I'll share with you an overview of these results and then some particular findings within each of the 4 ICF domains. So overall, the studies included a range of participants, including people with communication disability, carers and health professionals. And almost half of the studies were published between 2015 and 2020. And studies were published in a total of 59 journals. And this figure here shows that the number of journal articles in each of those journals. And the journal Aphasiology had the highest number of studies included in our scoping review. So when we looked at study designs, we found that the most common research study design were those of group design, which included RCTs, cohort studies, and pre and post case series studies. We also found 22 qualitative studies, and these used interview, focus group, and observational methods, and methodologies such as interpretive, phenomenological analysis, interpretive description, and ethnography. So when we look at the breakdown of the ICF domains, almost half of the articles addressed at least 2 of the 4 ICF domains, and each study was allocated 1 primary ICF domain. And this figure shows the number of studies per allocated primary ICF domain for communication disability. And as you can see, most studies addressed communication-related impairments, followed by environmental factors, and then participation and personal factors. This figure represents the type of communication disabilities addressed in more than 2 eligible studies of the scoping review. So the predominant communication disability addressed across the ICF domains was aphasia, which is represented here in the black columns, followed by a mix of neurogenic and sensory impairments, which are represented in the white columns, and cognitive communication disability represented there in ICF domain 1 in the grey column. Dysarthria was addressed in 3 studies only, and these were within a mixed neurogenic sensory group sample, and that's represented by the white columns here. And apraxia of speech was addressed in just 2 studies of the 128 included articles. So quite low numbers there for dysarthria and apraxia of speech. So if we now look at the ICF domains separately, ICF domain 1 looked at the communication-related impairment domain. And most studies investigated, most studies here investigating impairment-based aphasia therapies reported improved speech, language, and communication outcomes. There were mixed results of nil to general improvements were reported after neurostimulation therapies for aphasia, apraxia of speech, and dysarthria. And psychometric properties of assessment tools were also reported. And only 2 studies adapted tests for languages other than English. And that was the Greek version of the BDAE and the Chinese version of the language screening test. Moving on to ICF domain 2, environmental factors and barriers to communication accessibility were reported at the level of the health professional. So findings around level of knowledge, skills, and attitudes about communication disability, and also barriers and facilitators apparent in stroke unit structures and processes, such as the use of communication aids and equipment. Specific training. Some studies showed that specific training to overcome barriers and implement goal setting can be effective. And there were improvements reported after supported communication training in aphasia for health professionals and carers. Communication assessment, therapy, education, advocacy, establishing a therapeutic alliance, and adequate resources are all vital to managing environmental factors in communication disability. And accessible information provision is valued, important, and can be effective also. If we look at ICF Domain 3, which was looking at participation in communication and healthcare, we found that most studies investigating a blend of impairment and functional-based communication therapies for aphasia and dysarthria reported improved speech and language outcomes. And findings highlighted the importance of a person-centred approach, including culturally sensitive practice, increasing participation through the person with communication disability being able to self-report and rate their communication on rating scales, and also managing the therapeutic alliance and goal setting were highlighted as important aspects to increasing participation in communication and healthcare. Moving on to ICF Domain 4 and looking at communication and personal factors, there are a number of clinically feasible and reliable tools for screening mood. One study investigated the preliminary validation of cultural adaptation of the stroke and aphasia quality of life scale. Findings in this domain also highlighted the needs to address quality of life and psychological and emotional problems in post-stroke aphasia. And there was only one treatment study found, and it found that motivational interviewing it can be a clinically feasible therapy to address psychological problems after aphasia. So we've covered quite a bit of ground in terms of background method and results. Now I'd like to move on to some key discussion points, and we'll talk about rehab implications and future directions. So this study highlights there is some evidence to guide management of communication disability in the acute and subacute phases of care, particularly interventions that focused on communication-related impairments of aphasia. A coordinated and an integrated approach towards managing communication disability is needed to overcome the gaps in addressing the communication environment and access to and participation in healthcare and quality of life. There are communication supports to promote inclusion in healthcare decisions and rehabilitation services for stroke survivors with a variety of communication disabilities. And potentially these supports could be similar regardless of the features of the person's type of communication disability. And perhaps unsurprisingly, previous clinician reports demonstrate that clinicians do focus on impairment-based aphasia assessments and therapy, which aligns with the bulk of evidence that we found within ICF Domain 1 within this scoping review. So there is a clear and a high need for the development of interventions to target communication, access and functioning, and participation in everyday activities and aspects of quality of life. So moving into research and clinical innovations in the other domains are important. And this is reflected in clinical practice guidelines, particularly for aphasia rehabilitation. We also know that reports of speech pathology practice also reflect this lack of focus on participation and addressing personal factors such as quality of life, mood and psychological problems. And this again is consistent with what we found in this scoping review. There is a strong need to address and increase communication support training and enable participation through information provision and support of family members, goal setting, and developing the therapeutic alliance in the acute and subacute phases of stroke care. We need some high quality research to investigate interventions during the first 90 days after stroke with purposive recruitment of participants within this phase. And this is vital due to the importance of this phase of recovery in terms of neuroplasticity, potential for learning, and behavioural change. It's also vital because this is a period of time where there are challenging transitions in care from hospital to community, and there are also high costs of standard treatment in this phase. We need evidence to inform stroke clinical practice guidelines, but unfortunately the evidence to do so is insufficient at this stage. The Australian Stroke Foundation Stroke Living Guidelines aim to overcome limitations in clinical translation through a dynamic updating summary of stroke evidence. However, there are restrictions to the inclusion of high quality evidence other than large randomised control trials. So the guidelines may not always adequately reflect the findings of high quality but smaller scale studies, which could meaningfully add to the management of early communication disability. So sometimes we're missing out through the guidelines, hearing about the perspectives and preferences of survivors of stroke, families and health professionals, and this could be really helpful to informing our practice. So after understanding a little snapshot of our study and the scoping review, I wonder if there might be one or two things that you could take away from this seminar today. Is there a point that you could bring to your practice or workplace setting? It may be about goal-directed language and speech therapy, or it may be about supporting communication for the person with communication disability in a joint interdisciplinary therapy session or a family meeting. It might be putting in some consideration of the person's environment and how that could be managed to enhance their experience of communication. Or it might be putting in support techniques for a family member, or addressing an aspect of quality of life such as mood and psychological wellbeing. So takeaway points. I hope you've got some. So in summary, the management of communication disability is essential in the first 90 days after stroke. And it's essential to optimise healthcare communication and rehabilitation outcomes. There is really limited evidence to guide management of all communication disabilities after stroke, with a predominant research focus on aphasia. And most interventions address communication-related impairments, and there's less evidence addressing environmental factors such as communication support. There's less evidence around participation in communication and healthcare, and not terribly much evidence at all around personal factors such as psychological care. So future directions are really exciting because we've scoped the literature out in the field, but we really do need to do a systematic review and a meta-analysis of these existing interventions to identify the efficacy or the effectiveness of some of these interventions that we've included in our scoping review. And we also need to do this type of study to actually appraise the quality of the study methodologies of the studies that have been included in the scoping review. Research certainly needs to focus on a broader scope of communication disabilities in addition to aphasia. Often they are co-occurring after stroke, such as dysarthria and cognitive communication disability. apraxia of speech and sensory loss, such as vision and hearing impairments. Research is needed to address environmental and personal factors and looking at increasing engagement in participation in healthcare and everyday activities as well. And we also need to update our clinical guidelines. So there are some research priorities to address, and these are the perspectives and preferences of survivors of stroke and their family members and healthcare providers as well. And this needs to include the best available evidence across all of the ICF domains. So in conclusion, clinicians require the best evidence to optimise communication functioning and effectiveness in this complex area of practice. And this scoping review has highlighted the lack of evidence to manage communication disability within the first 90 days post-stroke and across the various types of acquired neurogenic communication disabilities and all ICF domains. But I don't want anyone to walk away disheartened, because there's certainly some lovely evidence that can guide our practice that we've highlighted in this study. It just means that we have more questions, and we need a further coordinated research and practice effort and approach to really strengthen the evidence base and tailor interventions to participants recruited within this important phase of recovery and healthcare provision. So thank you so much for your attention today and attending. Really appreciate the time that you've taken to listen in, and hopefully reflected a little as well on our own clinical practice. And I'd be really happy to answer some questions now. And get in touch if you'd like to. My email address is there, and my Twitter handle if you're on Twitter. Thanks, Kira.
Thank you so much, Caroline. That was a fantastic presentation. The body of work that you've actually sifted through and collated there is absolutely huge, and you've managed to synthesize that, bring that together and present today those results so clearly. So thank you so much for that presentation.
Kira, definitely a team effort to really gather all that data and analyse it. So I thank my co-investigators very much. So,
oh, well, thank you very much, Caroline. I think what's brilliant about this piece of work is that it really gives us an indication about the effectiveness of the interventions that we do know about and do have in those first 90 days post-stroke. But also it's really exciting to see those future directions and where we need to go as a research and clinical world in this area, and how we can maximise learning and those first 90 days for people with aphasia post-stroke. I'm just looking at the Q&A box here, and we have had a question come through for you, Caroline. Somebody has asked here, can you suggest any good resources for aphasia in neuro-oncology patients?
Thank you for your question. I'm not so familiar with specific resources in the neuro-oncology area. Please get in touch with us at the CRE, and we can certainly try to put you in touch with researchers that are specifically working towards resources for people with brain tumours and experiencing aphasia. Yeah, this study investigated looking at communication disability after stroke, and there are certainly resources that may be generic across different causes for aphasia, but if you were specifically wanting to look into neuro-oncology, we could help to link you in with people researching in that area.
That's another huge body of work that probably needs to be done as well. But as you said, this was focused on post-stroke, so we'll need to connect people together and resources. Oh, we have one here from Sally McVicker. She says, thank you for a lovely presentation. you advocate for communication intervention in the first 90 days. To what extent has the COVID-19 pandemic impacted on the rapid discharge of patients into the community? That's a fantastic question, Sally.
Hi, Sally. It's lovely to have you here. Thank you so much for your question. It certainly has been a major impact on how we communicate in our hospitals and communities. The impact of clinicians needing to wear masks, goggles, safety glasses and gowns has really impacted, and I know from personal clinical experience it's been very challenging and difficult. I've seen some lovely innovations, particularly shared on Twitter, of clinicians developing photographic name badges to use. There has been some great innovation and flexibility around how we can enhance that. I was thinking on this last night, Sally, about the impact of COVID-19 on healthcare communication, and we didn't actually pick up any studies in our scoping review, but I know that there are papers emerging that do describe the impact of COVID-19 on speech pathology services, and I can say from my clinical experience, we've had to change the way we've delivered health services via telehealth, and there've been some real positives from that, but also some challenges. So I think it's really great that people are starting to share their research in this area and innovations as well. I know the speech pathology department at Monash Health, where I've worked, they've really done great work to try to adapt to that. So yes, thank you for your question.
Yeah, it is a huge concern, isn't it, when you outlined in the background how important those first 90 days are, and then we are having people who are discharged so quickly from hospital in those first 90 days.
Yeah.
So yeah.
And I'd also remind everyone about the COVID-19 repository that is on the Aphasia CRE website, where resources have been gathered from around the world and from the UK, where you are, Sally, where people can share their resources. So there's a lovely discharge checklist that's been developed and included in that repository. So that can also help clinicians manage in that time frame.
That's fantastic. Thank you, Caroline. We have one here from Shelley, and she says, thanks, Caroline, huge amount of work. It really, really is. Do you get the sense that our colleagues in physiotherapy and occupational therapy have interventions more targeted at the activity, participation, the environment and the personal domains?
Yeah, hi, Shelley. It's a wonderful question, and thank you. It would be lovely to investigate our colleagues and their work practices. I'm unsure if you're referring to their focus on communication disability or within their own discipline with physio goals and OT goals, but I know in terms of communication, our interdisciplinary colleagues are interested in knowing how to support people with communication disabilities. So, and some of the studies included in this scoping review have put in communication support training for physios and OTs with good results. So I hope that answers your question. If anyone has any other ideas about what they think, how they think physios and occupational therapists are, approaching their practice, that would be really interesting to hear too.
That's fantastic. And Shelley, if that hasn't quite got to the crux of your question, please do put it back, another question into the Q&A box. But no, I do think that's really important that other healthcare professionals are equipped to communicate with people with aphasia as well during those first 90 days, so that those interventions and those contacts that they're having can be maximised. So yeah, that's a really important point as well, Caroline. We have another question here for you. Any suggestions on how to start incorporating the ICF framework into language assessments post-stroke? I have been using it to ask directed questions about each domain to find out if there are any barriers, reduce participation in daily activities, etc. But is there a more effective way?
Yes, so there are, the paper has described some impairment-based language and speech assessments that have been validated within the first 90 days. For example, the Brisbane evidence-based language test. For the domains of participation and environmental factors, a really helpful tool is the inpatient functional communication interview by Robin O'Halloran and colleagues. That's a lovely interview that is done with the person with a communication disability to explore those aspects of communication disability in the domains of activity, participation, and environmental factors. And then the personal factors are around quality of life. So we certainly have the stroke and aphasia quality of life tool, and other mood screening tools to help. So yeah, I hope that helps to answer the question, but there are various different examples of tools that could be used within each domain of the ICF.
Thank you so much for that really full and clinically applicable answer there, Caroline. Yeah, the IFCI that Robin O'Halloran developed is a fantastic tool to orientate that conversation. So yeah, thank you for sharing that.
That's our go-to.
Yeah. I want to share a lovely comment here from Bridget Noble. She says, as a significant other to a stroke survivor who is now 91 days old in the stroke journey, I cannot deny that all of your research is absolutely vital.
Thank you.
That's a lovely comment to have there from Bridget. And,
thank you, Bridget. Thank you for joining today.
Yeah, particular welcome, Bridget, and thank you for sharing that. That's great motivation for continuing this research. Thank you, Bridget. We have another question here from you from Jean. Thank you, Dr. Caroline Baker. It was a brilliant presentation. I'm Jean Pierre. Oh, sorry if I pronounced this wrong, Jean, but Jean Pierre from Spain. How can we start to implement this methodology with technology devices? What do you think?
Thank you for joining and your kind words. Yeah, so some of the papers in the scoping review do look at technology. So there were some therapies that used tablets. I wasn't able to highlight all the different types of interventions that are included in the scoping review, but there were definitely studies that used tech. So definitely it has a place, and especially during COVID-19, we've kind of needed to go to technology in a big way. And so this is something we're working towards as well, particularly in telehealth and online provision of interventions as well.
Yeah, it's definitely where a lot of rehabilitation and stroke care will be coming from in the near future and in now. Thank you so much for that, Caroline. We've got another question here from and I'm so sorry if I'm pronouncing these names wrong, but New Milton, and they ask why. Oh, this is an interesting question. Why did you do a scoping review as opposed to a systematic review? And how have researchers recruited patients with receptive aphasia? Many thanks. So we can start with the first bit there, Caroline. So why did you do a scoping review as opposed to a systematic review?
the scoping review was seen as the first initial step to look across all types of communication disabilities and across all the ICF domains. And so it's really about putting in the phases of research. So this study is sort of conceptualized as the first step to scoping out what is out there in the literature. And then the second step would be we need to go back into that data and perhaps update the search again, and to really look at a meta-analysis of which of these interventions are going to be effective, which haven't been, how much certainty is there around how effective the interventions are, and also appraising the quality of these studies. So I think because it's such huge work, we've needed to break it up into a couple of phases, and that's why we did a scoping review, to look broadly first. Yeah, I hope that helps. And then I guess recruiting people with aphasia, with receptive problems, it sort of speaks to some of the work you're doing, Kira, in how we recruit people with aphasia into research, because they are usually systematically excluded from stroke research. So that's something that the Aphasia CRE is working towards, to get people with aphasia into stroke trials. But each study, there were different levels of reporting on how people were recruited, and I guess that calls for the need in standardising how we report our studies and how we're recruiting people with aphasia into them as well. And there's been some lovely work around standardising that format of reporting.
Yeah. And hopefully from the CRE we'll be able to give a little bit more direction on how to, as you said, help stroke researchers to include people with aphasia in their research. We've got another question here from Roz Shand, and she says, thank you for a wonderful presentation. How do you recommend clinicians in acute and subacute services advocate for activity and participation-based assessments and interventions when the bulk of the literature supports an impairment-based approach? That's a very interesting question. Thank you, Roz.
Hi there, Roz. Thank you for your question. I think it needs to be discussed within departments how we're going to approach managing the aspects of communication functioning and participation in healthcare. There certainly is evidence there to support it. And as we can see, the bulk is within managing impairment, but we need to take that evidence probably to our teams and discuss ways that we might be able to make one or two changes to begin with around managing communication. It certainly is all valid therapy time and speech pathology session time to be enabling communication on the ward and across with our health, our colleagues who are working with us. So any work towards supporting the environment to enhance communication is all valid use of our time, and it might just be around perhaps talking with our team members and on how we do that.
Yeah, that definitely is the role of the speech pathologist, to advocate for that as well, and to advocate for the importance of those other domains in the ICF, as well as those impairment-based interventions. Thank you so much, Roz. We have 3 more questions and 1 more minute. So are you happy to quickly answer these 3 questions?
I'm happy, yeah.
Oh, thank you so much. So we have one here. It's from Bridget again. So thank you so much, Bridget. She said that it seems that therapists and medical teams in some areas could have a more cohesive intervention if this was embraced. Did that come up in your findings at all? She said that she's Brisbane-based and looking for more of this in every facet of aphasia assistance.
Cohesive intervention is this. Let me think. Kira, you might be able to help me as part of the investigative team, but I think that all I can report there is that there were studies that were done with stroke teams and to how different disciplines work together within the stroke team. And some of that was looking at communication support training, and that always has, across the studies that looked at communication support training, there were positive findings about improvements in other health professionals' knowledge and skills and confidence. So that's a really positive thing for the team to have implemented. And I guess some of my work around psychological care for people with aphasia looked at how the team together, they reported on how they manage psychological care. So there's some findings there around the stroke team and how they work. So I hope that helps answer some of your questions.
And even by publishing this work, Caroline, that would help to really show people the evidence that's out there, and people can use that evidence to advocate in their services. So it's really clearly brought together for them and ready-made package for people. Thank you so much again, Bridget. And we'll take this as the last question here from Roshali. Hey Caroline, greetings from India. So this has been a really international seminar here today. It was a lovely presentation. Thank you for your comprehensive takeaways. I wanted to know your inputs regarding group therapies in the acute phase. It is mostly a one-to-one person therapy. However, as a patient may move to subacute phase of recovery, he or she might benefit from support in groups and group therapies. I think that would help improve the domain of participation and personal factors. So were those studies with group therapies also included in the research? So it's a very good question.
So definitely we would have included group therapies if they were within the first 90 days after stroke. There may have been a few that were group-based therapies. I would need to go back to look at the detail of some of the therapies that we included, but definitely I think a lot of group work is also focused on the community beyond 90 days as well, so it can be beneficial then, but I can see how it could be beneficial also within the first 90 days if a person is well and wanting to participate in therapy in groups. So I think I'd need to go back to the detail to find those studies that used group therapies, but yeah, it's really promising. We've got the Katerina Hillary's peer befriending work that's happening at the moment and recently been reported on, which is called the Superb trial. So that's a lovely example of group work. But thank you for your question and your time.
Okay, and one very last one has snuck in, and I will ask this because it's the last one here, but thank you for a great presentation, Dr. Baker. How would you approach bi or multilingual individuals for assessment and treatment in the initial days? So was there anything that came up in the scoping review regarding that, Caroline?
No, I don't think there were any papers that looked at bilingualism. And I guess the limitation of our scoping review is that we only looked at publications written in English. So I'm sorry, I can't comment specifically about bilingualism in the first 90 days, because unfortunately, I don't think that was highlighted in the studies that we found.
Yeah, there's a little bit on validating assessments in different languages.
Yeah.
But actually, not
right.
on bilingualism. So
yeah,
perhaps that's an area for future development and future work.
Yeah.
Well, thank you so much, Caroline. We'll let you off the hook now.
Thank you.
But this has been an absolutely fantastic presentation and seminar, and it has been such a delight to be able to have this opportunity with you, Caroline. So thank you so much for your time and your presentation.
Thank you for your support, and thank you everyone for attending.
So we are very, very lucky that for our next seminar in this Aphasia CRE seminar series, that we will have Professor Jenny Crinian and Professor Alex Leff from the University College London, and they will be presenting on the clinical effectiveness of the Queen Square Intensive Comprehensive Aphasia service for patients with post-stroke aphasia. And this is a joint seminar with the Queensland Aphasia Rehabilitation Centre. So that's on the 16th of June at 8 to 9 British Standard Time, British Summer Time, and 5 to 6 here in Melbourne. So thank you all so much for joining us today and for your participation, for all those excellent questions. And thank you once again to you, Caroline, for this excellent seminar. So we'll see you all next month. Thank you for joining us.
Kira.
Thank you, Caroline.
Bye.